And now I invite Dr. Divya Balakrishnan. Divya is consultant retinal surgeon at Little Flower Hospital, Angamali. Divya will talk on pan-retinal photocoagulation versus anti-VEGF management of proliferative diabetic retinopathy.
At the outset, I would like to thank Dr. Thomas Cherian for giving me this opportunity to present before my two gurus, Dr. Thomas Cherian himself and Dr. Das. So how do I treat my patient of PDR, whether it is PRP or anti-VEGF? So before going to how do I treat, let's look at the evidence, what it says. So as we all know, diabetic retinopathy is a microvascular complication which lead to ischemia and result in retinal hypoxia. So the clinical features of PDR results because of this, which is NVE and NVD with vitreous hemorrhage and pre-retinal hemorrhage. As you all know, it is a progressive disease with progressive retinal ischemia. So the treatment aimed to target these retinal ischemia and the sequelae because of the hypoxia, that is anti-VEGF. So the aim of treatment in PDR is to reduce the VEGF levels and increase the oxygen supply. So these two treatment modalities, that is anti-VEGF and PRP, both works in this. So how do we decide? Any diabetic retinopathy patient, the first and foremost is the systemic control. And for PDR, PRP has been the standard of care after the landmark trial diabetic retinopathy study, which showed that with PRP, more than 50% of the patient, the risk of severe vision loss was reduced. But there are complications of PRP, which is a permanent peripheral vision loss, decreased night vision, or risk of diabetic macular edema. And despite PRP, patients can develop severe vision loss and can develop vitreous hemorrhage. So these are, this is a serial photograph of a patient who was treated with the PRP, and you can see despite the treatment, the patient developed vitreous hemorrhage over time. So is anti-VEGF a better option? So Protocol YES was the first trial which looked at the role of anti-VEGF in the treatment of proliferative diabetic retinopathy. So what does it show? So in this study, the patients were treated with monthly injections of ranibizumab versus PRP. So this was the first trial to show that anti-VEGF was non-inferior to PRP in treating PDR. So thus we have two options to treat PDR, anti-VEGF and PRP. And the main concern of anti-VEGF is that the risk of traction progression, and the advantage being that whether the visual field will be preserved. So the 5-year outcome of this study, which showed that only 66% of the patients could complete the trial, the follow-up period, and it showed that the visual acuity at the follow-up of 5 years was equal between these two groups, that is anti-VEGF and PRP. And over period, 19.2 injections were required in the group of ranibizumab, while only 5.4 injections were required in the group for PRP. But none of the group had any severe vision complications. So the main advantage of anti-VEGF being a preservation of the visual field, a subgroup analysis of this study showed that at the end of 5 years, the margin of difference between the visual field preservation at the 2 years were not there at the end of 5 years. So the difference had narrowed. So even in the patients with anti-VEGF, there was a reduction in the visual field loss. And Clarity was the next trial which looked at the comparison between aflibercept and PRP. So this was the first trial which looked at and showed that aflibercept is superior to PRP in improving best corrected visual acuity in cases of PDR, and it also showed that it is non-inferior to PRP in regression of neovascularization. The PRIDE study was another one which looked at compared between ranibizumab and PRP with PRP alone group. So this, at the end of 1 year, all the ranibizumab and the combined group had better visual outcome, but on observation, without any active intervention, when they followed up the patients at the end of 2 years, the advantage was not there, and adding on to that, there was an increase in the area of neovascularization in the group which had received anti-VEGF and the combination group. So if we discontinue the treatment of PDR with anti-VEGF, there is a chance that the disease can progress, and without intervention, the patient might lose vision. So when we consider treating the patient with the combination, which one would you do first? So this is a trial which looked at it. In that, the first group received anti-VEGF first, followed by PRP. The second group received PRP, followed by anti-VEGF. And this showed that the group which received anti-VEGF first required less extent of energy to deliver to get the desired burn, and also the need for retreatment was less in this group. So this study showed that anti-VEGF followed by PRP might be a better option. And another option which we think, or the advantage of anti-VEGF being whether it is disease modifying. So this was a study which was done only on 7 eyes, where they looked at after 3 monthly injections of aflibercept, they looked at the octa non-perfusion areas in octa compared with the microperimeter. So there it showed that in 52% of those areas which they looked at, there was an improvement in perfusion, and that compared with the improvement in the microperimeter. So there is a hope that maybe anti-VEGF might be disease modifying, even though other studies did not prove this. And coming to the next aspect, when we have a patient of PDR with vitreous hemorrhage, whether you take up for early surgery or whether we treat with anti-VEGF. Protocol AB by DRCR-NET was the first trial which looked at into this aspect, where they treated patients with vitreous hemorrhage with monthly injection of aflibercept and take up for early vitrectomy in the other group. So in the study actually, they looked at the results at the end of 1 year, 4 weeks, 1 year and 2 year. So they showed that at the end of 1 year and 2 year, there was not much of a significant difference between these two groups. But when they looked at the best corrected visual acuity at the end of 4 weeks, the group which had vitrectomy had a better visual outcome. So that is actually explainable by the kind of surgery which we do, intervention early by doing a vitrectomy. But another advantage of this study was that the recurrent vitreous hemorrhage was seen in 49% of the patient who received aflibercept, while only 15% in the vitrectomy group. Now, in the subgroup, in this study, they did a subgroup analysis. If the patient had presented with a worse visual acuity, that is less than 20/800, does a vitrectomy has an early role? So this showed that those patients with a poor visual acuity, if you take up them for early vitrectomy, they had a better visual outcome. Now, as I mentioned earlier, whether there is a risk of progression of tractional retinal detachment after you give anti-VEGF, which is a scare for many of us. But they analyzed the pooled data of various studies in the DRCR-NET. They showed that the cumulative probability of the progression was comparable with the control group. So the risk, as we anticipate, is not there as we think. The major concern is the patients who are lost to follow-up. So in this, even in the protocol as we saw that almost 50% of the patient actually was lost to follow-up. And when we did the analysis of those patients who were lost to follow-up, those patients who had received anti-VEGF actually had a higher risk of developing tractional retinal detachment and neovascularization compared to eyes which had received PRP. So the main concern is that if the patient is lost to follow-up, then the risk of patient presenting with complications is on the higher side. On the other hand, we already have evidence from the ETDRS trial that the patients who are treated with the PRP, 42% of them retain 20/20 vision over a period of 16.5 years. And even if the patient develops a vitreous hemorrhage, when we do vitrectomy, the visual acuities are comparable. So in real world practice, loss to follow-up is the most scary thing when you treat a patient with anti-VEGF alone. So as of now, this is an article which by Dr. Rajiv Raman. So they say that selecting a patient with PDR for anti-VEGF therapy as of now is active PDR in which despite good PRP, there is a persistence of new vessels, or when there is a difficulty in performing PRP, preoperatively before a diabetic vitrectomy to reduce the risk of intraoperate bleeding, or an anterior segment neovascularization, or DME with PDR, or an adjuvant to PRP. So these are few cases wherein the patient presented with vitreous hemorrhage. We could not do laser, so the patients were given anti-VEGF, and followed by the resolution of vitreous hemorrhage, PRP was added. So I don't treat PDR patients by monotherapy, use it as an adjunct. Thank you.
Thank you, Divya. A PDR with a pre-retinal hemorrhage at the macula, would you go for a PRP or an anti-VEGF?
At the premacular area, if there is no vitreous hemorrhage, I still go for PRP first. Then only I go for a vitrectomy.
Any further questions to Divya?